these patients, as in every melanoma patient or mole patient in our clinic, we always teach sun avoidance, of course, covering up with clothes and using sunscreen on the other areas when exposed to UV. Of course, their main risk is the genetics. And I always explain to them that the main risk is the genetics, and therefore we need to see them anyway. But we do think that it's recommended to have a good sun avoidance program as well, because we do know that in Australia, for instance, where they are more exposed to sun than in Norway, the mean age for melanoma in these families are lower. So we recommend cover up with clothes. Clothing is the most important sun avoidance program, and hats, of course, and the skin that you can't avoid sun, you use a sunscreen, and we recommend 50 plus, SPF 50 plus, and I think people do so. They go to Spain in the summer and they come back almost as pale as when they went. And then we also talk about self-examination of the skin, which ideally should be done monthly in front of a mirror, and then in these days also with iPhone you can take picture of your back, and just these coarse pictures you can compare with new ones after a month or so and see if it's any big changes. My experience is that it really rarely happens because we see them so often, but we do teach them to be aware of every change. I mean, we just use the word change, and we explain to them if it's growing or it's bleeding or it's getting darker in any way, you should make a new appointment, and we see them quick. When people arrive with the suspicious genetics or the confirmed genetics, we always take the photographs, and it includes the macroscopic photograph of the whole skin with the moles and everything from every angle, and it's more like a fixed procedure. So the nurse have to take the picture of every part of the body to fulfill the program. And then we also make dermoscopic pictures, which is close-up of every mole. And then if the patient has many moles, we just do a selection. The darkest, the largest, and some other, just to compare from time to time. I would say that many patients who are mutation carriers tend to have lots of moles, but not everybody. It varies a bit, I think. But people with a lot of moles who find it difficult to do self-examinations will have the opportunity to get more often to our clinic. Patients in their 20s, for instance, we see like once a year. And then we tell them to take contact if it's any new moles that they are not expecting, or if it's any changes or anything that they want to discuss. So they have this really open line, but we see them once a year most of the time. And then you have the patients in their 30s and 40s and even who still had no melanomas. Usually we see them twice a year. And we do the total body mapping and we do the total surveillance and talk to them. And then you have the patients who already experience one or more melanomas. And then it's more like on an individual basis. Some of them goes as often as every third month, twice a year some, and we always have this open line that they may make a phone call whenever it's suitable. The people that comply with the surveillance program in our department, I have never seen invasive melanoma with thickness more than like 1.5 millimeters, I think. And we have never had any with metastatic disease or who have died from melanoma.